Good day, colleagues. For the next 40 minutes or so, I'll be discussing the life cycle of malaria parasite and severe malaria. Let us begin with one sentence that will organize the whole lecture. The life cycle is the map. The blood stage causes illness, and sequestration explains severity. Please do not approach this life cycle as a colorful diagram to memorize. Approach it as a sequence that explains incubation, symptoms, microscopy, transmission, and organ dysfunction. As future pediatric residents, you will meet malaria cases repeatedly. But in this primary examination that you're about to write, you will be expected to go beyond just recognizing the diagnosis. You must be able to explain why the child is febrile, why the hemoglobin falls, why breathing becomes deep, and why a child becomes comatose through the lens of this life cycle that I'm about to teach. That is the journey it will take in the next 40 minutes or so. By the end of this lecture, you should be able to move through 3 levels of thinking. First, describe complete cycle in human and mosquito. Second, identify the infective, diagnostic, and pathogenic stages without hesitation. Third, use the biology of malaria parasite to explain severe disease. You will notice that the objective moves from description to explanation and then to application of knowledge. That is exactly how postgraduate questions are often framed. A recall question may ask you for the infective stage, but a stronger question will present a child with coma, acidosis, or severe anemia, and then ask you to select the mechanism that best explains the findings expressed in that question. Keep asking yourself when you are going through this, what stage is involved, what tissue is affected, and what pathological process follows. Malaria remains a major cause of preventable childhood illness and death. The most recent WHO estimate for 2024 was about 282 million cases and 610,000 deaths worldwide. Roughly 95% of the global burden is in African region, and children under 5 account for about 3/4 of malaria deaths in that region. Those numbers give us context, but pathology will tell us why an apparently familiar febrile illness becomes a rapidly fatal multi-system emergency. In Nigeria, a positive malaria test can easily create premature closure. We stop thinking because malaria is common. Today, I want you to do the opposite. The more common the disease, the more precisely you must understand it well. Life cycle knowledge supports diagnosis, prevention, treatment, while pathophysiology helps us to recognize the child who is about to deteriorate. 5 species are routinely recognized as causes of human malaria. Plasmodium falciparum is the dominant cause of severe malaria and death in Africa because it can invade red cells of all ages and because infected cells adhere and sequester. Plasmodium vivax and Plasmodium ovale prefer reticulocytes and they can leave dominant hypnozoites in the liver, so relapse is possible. Plasmodium malariae prefers older red cells and they have a 72-hour cycle and may persist at low density. It is clinically associated with cotton malaria and nephrotic syndrome. Plasmodium nosal is zoonotic and has a 24-hour erythrocytic cycle, so parasitemia can rise quickly. The examination precision is this. Do not say that only Plasmodium falciparum causes severe malaria. Say severe malaria is predominantly due to P. falciparum, while severe vivax and nosal disease are recognized. That wording is both accurate and defensible alternative. Now let us look at the whole cycle before we divide it into parts. An infected female Anopheles mosquito injects sporozoites. The sporozoites enter hepatocytes and multiply silently. Merozoites are then released into the blood. invade red cells, and begin the asexual erythrocytic cycle. That blood stage produces symptoms and pathology. Some parasites differentiate into gametocytes, another mosquito then picks them up, and asexual development continues within the mosquito. Therefore, the mosquito is the definitive host because asexual reproduction occurs there, while the human is the intermediate host. Let us make this an examination anchor explicitly. The stage that is infective to human is the sporozoite. The stage that is infective to mosquito is the gametocyte. The diagnostic stage are the blood stage forms, and the pathogenic stage is the asexual stage form. The mosquito feeds, sporozoites are deposited in the skin and rapidly reach the liver. Within hepatocyte, they undergo exoerythrocytic schizogony, producing many merozoites. The key clinical point here is that this phase is usually silent. Red cells are not yet being invaded and ruptured. So, the classical fever and anemia have not begun here. The liver phase, therefore, helps explain the incubation period and the action of the pre-erythrocytic preventive strategy. It also explains why the RTSS and the R21 vaccines target the cyclosporozoite protein. Then they are trying to stop the parasite before or during hepatocyte invasion. So use this memory line. Liver stage equals silent notification before symptom. When symptoms begin, think of the blood stage. This slide addresses a frequent examination concern. A relapse is not the same as recrudescence, and neither is it the same as reinfection. Relapse occurs when a dormant liver hypnozoite reactivates. This is classically seen with Plasmodium vivax and Plasmodium ovale. Recrudescence occurs when blood stage parasites were not completely cleared during treatment and later rises again. Think inadequate treatment in this case. Also think about resistance and think poor adherence to medication or persistent infection. A reinfection is a completely new incubation from another infected mosquito in an endemic area. All these possibilities may be discussed, but the mechanism distinguishes them all. Here is a quick test that you must think about. A child previously treated for falciparum malaria returns with parasitemia. Should your first answer be hypnozoite relapse? No. Falciparum does not form hypnozoite. Think recrudescence or reinfection. On human stage of malaria life cycle, merozoites released from liver invades red cells and develop from ring form into tropozoites and then schizons. Nuclear division produces new merozoites when the schizons rupture. Merozoites, parasite products, and red cell content are then released and the cycle begins again. This is where clinical malaria starts. Repeated cycles increase parasite density, destroy red cells, and activate innate immunity. Some parasites leave the asexual cycle and becomes gametocytes, which are important for transmission, but are not the main cause of the patient's symptoms. Link this morphology to the pathology. The ring forms, the trovozoite, the schizons, the rupture, then the fever. Inflammation, anemia occurs. The blood stage is therefore both the symptomatic stage and the principal pathogenic stage. Here, let's discuss species differences that explain severity. Red cell preference places a biological ceiling on parasite density. Vivax and ovale largely select reticulocytes, and Malaria select older cells. Falciparum can invade red cells of all ages, so the much larger proportion of the circulating red cell mass is available. Add sequestration and total parasitemia biomass may become far greater than what is visible in peripheral blood smell. Nocile, on the other hand, deserve our attention because its reticulocyte cycle is only just 24 hours, permitting rapid daily multiplication And do not reduce severe parasitemia to the statement it causes high fever. No, the more complete answer should be that broad red cell invasion permits high biomass, while cytoadherence and sequestration hide mature infected cell in the microvasculature and drive organ injury. Let us switch over to the part of the mosquito stage of malaria parasite life cycle. A mosquito feeding on an infected person takes up male and female gametocytes. In the mosquito gut, gamete forms. Fertilization produces a zygote. The zygote elongates into an eukinete, and the eukinete crosses the gut wall into to form an oocyst. The oocyst produces sporozoites, which migrate to the salivary gland and are ready for the next blood meal. Sexual reproduction therefore occurs in the mosquito, not in the human blood. The mosquito must also survive the long enough period of sporogony to be completed. This part of the life cycle explains why vector control and transmission blocking approaches matter to prevention of malaria. Remember, the bridge gametocyte leaves one human and allows parasite to reach the next human being. Now let us look at these anchors from the life cycle of malaria parasite. Let us rehearse the high yield anchors rapidly, quick. Infective to human, then the answer should be sporozoite. Infective to mosquito, the answer should be gametocyte. Responsible for symptoms, the answer should be the asexual blood stage. Responsible for relapse, the hypnozoite of the vivus or oval should be your answer. What is commonly seen in the peripheral blood film should be the answer should be Plasmodium falciparum, particularly the ring form and the gametocyte, because mature trophozoites and chrysomes tend to sequester. The important examination lesson for you here is that life cycle of malaria parasite questions are often disguised as clinical questions. So a question about recurrent vivus malaria is really testing hypnozoites. A question about smear containing mostly rings is in a very ill child is really testing sequestration. Do not answer by just pattern recognition alone. State the biological reason when you are asked. At this juncture, it is important for us to understand why malaria causes fever. Fever is produced when blood stage chrysomes rupture and release parasites and red cell products. Glycosyl phosphatidylinositol, imozoin, nucleic acid, and damaged cell signal activate macrophages, monocytes, dendritic cells, and endothelial. Cytokines, on the other hand, such as TNF-alpha, interleukin-1, and interleukin-6, together with prostaglandin E2, reset the hypothalamic temperature set point. So, the mosquito bite itself does not cause the febrile paroxysm, and the salient liver stage does not directly cause it too. The classical periodic fever reflects synchronized erythrocytic rupture, but Falciparum infections are often asynchronous, especially early in illness. So the fever may be irregular and not as paroxysmic as the other species. That is a useful safeguard against rejecting malaria simply because the fever pattern is not following the textbook stuff. Inflammation is not entirely harmful. A controlled innate response helps limit parasite growth and promote phagocytic clearance. The problem is an excessive or poorly regulated response, particularly when it occurs alongside high parasite biomass and sequestration. Cytokines activate endothelium, increase adhesion molecule expression, and worsen metabolic stress. They also contribute to fever, impaired erythropoiesis, hypoglycemia, and tissue injury. So think of inflammation as an amplifier. It may start as a defense mechanism in itself, but it can intensify cytoadherence, vascular dysfunction, and organ damage. Therefore, when an option says cytokine causes fever, that may be correct but incomplete. The best option may show how cytokines connect with fever, with endothelium activation and metabolic disturbance. Symptoms that you see during malaria fever are in themselves mechanisms in disguise. This is how I want you to read clinical features in cases of malaria. Fever, chills, and rigors point to red cell rupture and inflammatory mediators. Headache, malaise, and myalgia reflect systemic cytokine signaling. Vomiting and poor feeding may reflect inflammation, acidosis, gut sequestration, or poor perfusion. Anemia is not simply the rupture of infected red cell. Uninfected red cells are also cleared, and marrow production is suppressed very often. So thrombocytopenia may result from splenic pooling, activation, consumption, and immune removal, and it does not automatically mean disseminated intravascular coagulation. Coma and seizure requires you to think about cerebral sequestration, endothelial injury, and reversible metabolic contributors such as hypoglycemia. So symptoms and mechanism made visible at the bedside each time you see a case of malaria. So the current framing for severe malaria is what I want to discuss in this session. Severe malaria means malaria that is accompanied by vital organs dysfunction, severe metabolic disturbance, and another high risk feature requiring urgent parenteral treatment and supportive care. A positive parasite test alone does not define severe malaria. In endemic area, asymptomatic parasitemia can coexist with bacteremia or bacterial meningitis, sepsis, or another cause of coma. At the same time, do not wait for every laboratory result when a child has unarousable coma, prostration, repeated convulsion, shock, or deep acidotic breathing. The child can deteriorate rapidly. Also, note the change from some older teachings that we used to tell those days that vomiting alone and hyperparathysemia are not sufficient to define severe malaria. The central concept in all cases of severe malaria is that there is organ dysfunction, not simply intense symptom or a positive test when it comes to malaria parasitemia. So now I'm going to present an updated table for you to take note of as against some of the previous definitions of 1990 and 2000 by WHO. So you need the core criteria and you must know it, and there are also common thresholds that you need to pay attention to. For instance, impaired consciousness simply means unarousable coma, and it's often expressed as a Glasgow coma scale below 11 or a Blantyre coma score below 3. After alternative causes are considered. Prostration means inability to perform age-appropriate function such as sitting without support, standing, walking, and feeding or drinking. So repeated measures, general convulsion, for instance, commonly 2 or more in 24 hours are a danger feature, and they remain signs of severe malaria. Acidosis may be identified by deep breathing, bicarbonate below 15 millimole per liter, base deficit above 8, or lactate above 5. Hypoglycemia is glucose below 2.2 millimole per liter. Severe malaria anemia in a child is hemoglobin level below 5 grams per deciliter, or hematocrit below 15%. In the presence of parasitemia, some WHO table further specify a minimum parasite density, renal impairment, jaundice with another severe feature, shock, pulmonary edema, significant bleeding, haemoglobinuria, and hyperparasitemia are also important. So thresholds are simply across guideline. So as candidates preparing for primaries, you need to identify the framework being used and prioritize the organ dysfunction. This slide presents some of the common patterns of severe malaria in African children. Children with severe malaria do not always resemble adults. In African children, the major pattern are cerebral malaria, severe anemia, and metabolic acidosis, often with hypoglycemia. Cerebral malaria presents with coma, seizure, and sometimes abnormal posturing or later neurological sequelae. Severe malaria anemia is especially prominent in younger children with repeated infections and high hemolytic burden. Deep breathing may be the respiratory expression of lactic acidosis rather than the primary lung disease. Hypoglycemia can be silent and rapidly fatal. Shock should make you search for bacterial sepsis because severe malaria and sepsis can coexist. Do not force a child into one of these syndromes. The same child may have coma, anemia, acidosis, and renal injury spontaneously. This slide is an attempt to present to you a unifying pathogenesis model. This is central organizing slide that is connecting all the plausible causes of severe malaria. Please note that severe malaria is not caused by just one isolated mechanism. Four interacting processes reinforce one another. First, high parasite biomass produces hemolysis, antigen load, and metabolic stress. Second, parasite products provoke host inflammation. Third, cytoadherence, rosetting, and sequestration obstruct microvasculation. Fourth, endothelial activation and altered hemostasis produce leak, impaired perfusion, and coagulation disturbance. These pathways converge on a final common problem, which include inadequate oxygen delivery and impaired oxygen use. The result is often tissue hypoxia, lactate accumulation, acidosis, coma, respiratory distress, kidney injury, shock, and if not reversed, death. When you are unsure of an answer, please return to this model and ask which part of the pathway best explain the clinical findings presented to you. From this point forward, I will attempt to explain some of the components of the unifying pathogenesis model I present in the previous slide. Parasite biomass is the total burden of parasite in the body, not merely the number seen in a peripheral blood film. Falciparum invades red cell of all ages, as I said to you earlier, and this allows rapid expansion. As sporozoites or trovozoites mature, infected cells adhere in the deep microvasculature. So, the peripheral film may contain mostly young green forms, while a larger mature biomass is being hidden. This hidden biomass drives hemolysis that we often see in malaria cases, inflammatory antigen load, and metabolic demand. Plasma Falciparum histidine-rich protein 2 can estimate total biomass in research setting, but it is not a routine bedside test in most Nigerian hospitals. The examination point is simple. A model or a modest peripheral parasite count does not always mean mild disease, especially when the clinical picture suggests extensive sequestration and the symptomatology also supports so. Now, to understand this further, a normal red cell is flexible and passes through the spleen and microcirculation. Falciparum changes that cell. Parasite proteins are exported to the red cell membrane. Knobs form on the surface, and Plasmodium falciparum EMP1, a form of protein knob, is displayed. And PFEMP1 is the parasite adhesion ligand. It is not an endothelial receptor. It binds the host receptor such as CD36, ICAM1, EPCR, VCAM1, and in placenta malaria, chondroitin sulfate. Our knobs improve the presentation of PFEMP1, while antigenic variation of genes help the parasite evade immunity. So, the biological advantage to the parasite in this case is avoidance of splenic clearance. So, the cost to the patient is sequestration, impaired microvascular flow, and endothelial activation, as well as organ dysfunction as its consequence. Another mechanism by which severe malaria occurs is cytoadherence, rosetting, and sequestration. These terms are related, but they are not synonymous. Cytoadherence is the binding of infected red cell to the vascular endothelium. Rosetting is the binding of an infected red cell to the uninfected red cell, producing a flower-like cluster. Platelet mediate this clumping, and this occurs when platelet bridges infected red cells. Sequestration is the accumulation of matured infected cells in the deep vascular bed, such as the brain, the gut, the kidney, lungs, liver, and placenta. So together, these processes narrow or obstruct the microcirculation and reduce local oxygen delivery. Add endothelial activation to this, the vessel becomes even more adhesive. The key chain is adhesion plus cellular aggregation leads to impaired flow. Impaired flow leads to local hypoxia. Local hypoxia contributes to organ deformity. At this point, it's important for us to understand host receptor and clinical syndrome, how they relate. Please do not memorize receptor lists without understanding the logic. The parasite ligands bind a host receptor, and the binding phenotype helps determine where sequestration will occur and what syndrome may follow. CD36 support adhesion in many vascular beds. ICAN1 is upregulated on inflamed endothelium and is associated with cerebral binding phenotype. EPCR binding variants are strongly linked with severe and cerebral malaria and may disturb the protective potency pathway. Chondroitin sulfate A explain placenta sequestration by VAR2CSA expressing parasite. CR1 blood group antigen and other red cell factors also participate in rosetting. So it is important for you to remember that parasite ligands, when added to host receptor, produces an adhesion phenotype, and the adhesion phenotype contributes to the tissue tropism and severity of malaria. Please note that a peripheral smear sample represents circulating blood, not the deep microvasculature. Early ring forms circulate in this blood. As the parasite matures, they express NOPs and PFEMP1 adhere to endothelium and sequester. Therefore, routine Plasmodium blood film often show ring form and gametocyte, but few mature trophozoites and chizones. This does not mean that the mature parasites are not present. It means they are hidden somewhere. Indeed, seeing Falciparum chizones in the peripheral blood can be a danger sign because it may reflect very heavy infection and failure of sequestration mechanism. So always judge severity clinically and not by blood film. So the parasite only rings does not mean the child does not have a deep-seated parasite hidden somewhere. Now let us take a deep dive into the endothelial role in severe malaria. The endothelium is not a passive pipe. Infected red cells, adhesion, and inflammation mediators activate endothelial cells. Activated endothelium expresses more ICAM1, VCAM1, heat-selectin, and other adhesion molecules, which encourages further sequestration. Angiopoietin imbalance reduce nitric oxide, bioavailability, and glycocalyx injury worsen vascular dysfunction. EPCR binding parasites may interfere with anticoagulant and cytoprotective protein C signaling. The consequences are barrier leakage, impaired perfusion, and procoagulant tendency, and local tissue hypoxia. This creates a vicious cycle. Adhesion activates endothelium. Activated endothelium becomes more adhesive. More parasites get sequestered. Perfusion further worsened. Severe malaria is therefore both a parasitic disease and also a vascular disease on the other hand. It is important also to note that platelet, leukocytes, and altered hemolysis play some role in severe malaria. Platelets and leukocytes amplify microvascular process. Platelet can bind activated endothelium and infected red cell as well, promoting clumping and sequestration. Platelet-derived mediator increase endothelial adhesiveness and permeability. Leukocytes recruited through E-selectin and ICAM1 will add to inflammatory injury and also to mechanical obstruction. A coagulation is often activated and fibrin formation may further narrow the flow of blood. However, frank disseminated intravascular coagulation is less common than in bacterial sepsis. Okay. Likewise, thrombocytopenia is common but does not automatically mean that the child is bleeding. Think about activation, splenic pooling, consumption, and immune clearance. So the best answer to any question around this is to link platelets and leukocytes to endothelial activation, microvascular obstruction, and disturbed homeostasis. Now, let us look at some of the major organ syndrome in severe malaria. Cerebral malaria, for example, is falciparum parasitemia with unarousable coma that cannot be explained by any other cause, usually with glucose coma score below 11 or a blantar coma score below 3. The coma should persist after the immediate post-ictal period and after hypoglycemia has been corrected. The crucial caution is that a positive malaria test in a comatose child does not automatically prove malaria is the cause. So check glucose immediately, consider meningitis, sepsis, encephalitis, toxic ingestion, hypoxemia, severe anemia, and prolonged post-ictal depression. Treat suspected severe malaria urgently, but continue searching for alternative cause. Malaria retinopathy, retinal whitening, vessel color changes, and hemorrhage can increase the diagnostic specificity because retina reflects the cerebral microvasculature. Thinking about the pathophysiology of cerebral malaria, coma is the visible end of microvascular, endothelial, inflammatory, and metabolic process. Infected red cells sequester in the brain microvessel. Endothelial activation follows. Adhesion molecule increase and the blood-brain barrier becomes dysfunctional. Microvascular obstruction impairs cerebral perfusion, while inflammation and barrier injury promote swelling and tissue dysfunction. EPCR and ICAM1 binding PFEMP1 variants are particularly relevant in this situation. Metabolic problems include hypoglycemia, acidosis, severe anemia, fever, and recurrent seizure. And this can worsen cerebral injury in case of cerebral malaria. Therefore, cerebral malaria is not simply parasite inside the brain. It is sequestration plus endothelial dysfunction, inflammation, impaired perfusion, and metabolic stress. That multidimensional is the answer to this. Is the stronger answer than a single mechanism explanation. People often think severe malaria anemia is caused by the fact that infected red cell rupture. That is true, but it is not enough. Infected red cells are lysed and phagocytosed. At the same time, many uninfected red cells are removed because inflammation complements deposition, altered deformability, and splenic activation mark them for clearance. The marrow response is also inadequate. Cytokines suppress erythropoiesis. This erythropoiesis produces ineffective red cell, and hepcidin limits iron availability. Splenic pooling further reduces circulating red cell mass. Recurrent infection, malnutrition, ailments, and haemoglobinopathies, as well as GSP-related hemolysis, may worsen this picture also. The high quality answer that you should be thinking about when asked this kind of question is that severe malaria anemia results from destruction of infected and uninfected cell plus impaired marrow compensation. Respiratory distress in a child with severe malaria is often metabolic rather than primary pulmonary condition. Sequestration and microvascular obstruction reduce tissue perfusion. Severe anemia lowers oxygen carriage. Fever and seizures increase oxygen demand. Cells shift towards anaerobic metabolism. Lactate rises and metabolic acidosis develops. Hypovolemia and renal impairment may also reduce acidic clearance. The child responds with deep labor breathing to lower carbon dioxide and compensate for acidemia. Therefore, when the chest is relatively clear but breathing is deep and labored, think metabolic rather than automatically diagnosing pneumonia. Hypoglycemia is another common and treatable but easy to miss complication of malaria. Parasite consume glucose. The ill child has poor intake and may be vomiting. Hepatic gluconeogenesis may also be impaired, and quinine, where it is used, can stimulate insulin release. The threshold shown here is below 2.2 millimole per liter or below 40 milligram per deciliter. So clinical features will include sweating, altered level of consciousness, convulsion, and unexplained deterioration. But the child may show few warning signs. So this is why glucose must be checked immediately in every child with suspected severe malaria, coma, or seizure. So hypoglycemia may mimic cerebral malaria, and it may coexist with it or worsen it as well. Kidney injury in severe malaria cases results from several converging mechanisms. Sequestration, hypoperfusion, reduce renal blood flow. Hypovolemia worsen perfusion. Inflammation injures the microvasculature, and free heme pigment can damage renal tubules as well. So monitoring urine output, urea and creatinine are important because renal injury may be clinically silent in early cases. So jaundice may reflect hemolysis plus hepatic dysfunction and is more meaningful when accompanied by high parasite burden. Other manifestations of severe malaria include shock, pulmonary edema, and bleeding. These manifestations are less common in African children than anemia, coma, or acidosis, but they are high risk when present. Shock may reflect hypovolemia, severe acidosis, capillary leak, metabolic stress, or concomitant bacterial sepsis. Treat malaria urgently, but actively search for sepsis anytime. Pulmonary edema or acute respiratory distress may result from endothelial leak as well, inflammation, microvascular dysfunction, or excessive fluid administration. This is why indiscriminate fluid boluses are dangerous. Thrombocytopenia and coagulation changes are common, but clinically significant bleeding, not a low platelet count alone, is severe feature. When shock, respiratory compromise, or bleeding occurs, think urgent resuscitation plus a search for sepsis, capillary leak, and coagulopathy. Now let's discuss who is at higher risk of severe cases of malaria. Risk emerges from interaction of parasite, the host, and the context. Parasite factors include high biomass, adhesive PFMP1 variant, and strong rosetting and sequestration phenotype, mixed infection and drug resistance. Host factors include young age, pregnancy, absent or waning immunity, malnutrition, HIV or other immunosuppression, severe anemia, splenectomy, and relevant red cell traits. Context matter as well. High transmission, delayed diagnosis, poor access to acetonis or supportive care. Substandard medicine, displacement, conflict, and poverty all increase the risk of severe malaria. In endemic setting, partial immunity reduces the likelihood of severe diseases, but does not prevent infection. Travelers, migrants, and displaced people may have absent or lapsed immunity. Do not memorize this list in isolation, please. How each factor modifies parasite burden, immunity, or access to timely care needs to be think through. Several inherited red cell traits modify malaria risk, but none should be thought as an absolute shield. Sickle cell trait reduces the risk of severe falciparum malaria through impaired parasite growth, enhanced clearance, and alter adherence or immune recognition. Fetal hemoglobin and maternal antibodies provide partial protection in early infancy, but young infants can still develop malaria. Blood group O is associated with less rosetting than non-O groups. G6PD deficiency may reduce malaria risk in some settings, but increase susceptibility to oxidant hemolysis. Duffy Negativity strongly reduce classic P. falciparum, P. vivax rather, invasion, because the Duffy antigen is an important receptor. But Duffy negative vivax infection are now documented in Africa, unlike what was previously reported. The precise statement should be strongly protective and not absolute resistant. Anytime you would like to discuss this, please say strongly protective but not absolute resistance to any of these factors. As part of this lecture, I consider it important to discuss why parasite biology still matter to drug resistance. Drug resistance belong here because delayed parasite clearance, prolonged antigen exposure, hemolysis, transmission, and the risk of deterioration. Artemisinin-based combination therapy remains the standard for uncomplicated falciparum malaria, and oral artemisinin monotherapy should not be used. Artemisinin partial resistance means delay parasite clearance, and it does not automatically mean the entire combination treatment has failed. WHO now documents confirmed resistance in several African countries, especially in East Africa, with a complete oral ACT when the patient can tolerate it. Now, for the purpose of this lecture, please remember the biological chain as follows. Parasite survivor under drug pressure becomes prolonged parasitemia, and prolonged parasitemia becomes a clinical and public health problem. Always remember this. Furthermore, I consider also it important to mention how the life cycle of malaria parasites relate to the vaccine and talk about its usefulness in clinical practice. The vaccine slide that I'm showing you bring us back to stage specific biology. RSTS AS01 and R21 matrix M target the circumsporozoite protein on the sporozoite. Their aim is to reduce successful hepatocyte invasion and pre-erythrocytic development. WHO recommends these vaccines for prevention of falciparum malaria in children living in endemic area, prioritizing moderate and high transmission settings. The important conceptual contrast is that the vaccine acts early at the sporozoite and early entry stage, whereas clinical illness and severe disease are produced mainly by the blood stage of the parasite life cycle. Vaccination therefore reduces risk but does not remove the need for vector control, chemoprevention where indicated. Parasitological diagnosis and prompt treatment are still very important in spite of the availability of vaccine. Now let us convert all the mechanisms we have been discussing into action. Because the blood stage causes illness, confirm malaria parasitologically whenever possible rather than diagnosing every fever as malaria. Because sequestration hides biomass, assess severity clinically even when the measured parasitemia seem modest. Because cytokine and metabolic stress drive deterioration, check glucose, assess acid-base status, lactate, respiratory pattern and hydration. Because anemia reduces oxygen delivery, check hemoglobin or packed cell volume early and prepare transfusion when the criteria are met. Because cerebral malaria has important differentials, treat malaria promptly while checking glucose, controlling seizure, and considering meningitis or sepsis. Because severe malaria progresses rapidly, give parenteral artesunate without avoidable delay and complete treatment with an oral ACT when the child can take it. Basic science should change what you do at the bedside. I would like to end this lecture by compressing the entire lecture into just 5 statements. First, the liver stage is usually silent, while the asexual blood stage produces symptoms and severe disease. Second, falciparum is particularly dangerous because it combines broad red cell invasion and high biomass with cytoadherence, rosetting, and sequestration. Third, fever, anemia, coma, acidosis, and hypoglycaemia are mechanisms made visible at the bedside. Fourth, severe malaria is the malaria with organ dysfunction or high-risk metabolic and microvascular disease, not merely a positive blood test. Fifth, a strong postgraduate candidate should be able to explain the path from parasite stage to tissue injury, clinical findings, and urgent action. Please say this final sentence with me. Life cycle explains symptoms, sequestration explains severity, organ dysfunction define severe malaria. I've listed these key sources for further revision. So prioritize the WHO malaria guideline and WHO report, the CDC life cycle, and the morphology materials on this slide. Okay, all these papers are accessible to you for your further reading. Thank you very much. I will leave you with the 3 boxes summary on this slide. The life cycle explains where the parasite is, when symptoms begin. Sequestration explains why parasite disease can become a microvascular emergency, even when the peripheral blood film looks deceptively modest. Organ dysfunction define severe malaria and determine the urgency of care. As you revise, do not ask only, what is the answer? Ask yourself, what mechanism made that answer the best option? I am happy to take any question from this time. Thank you.